So, what exactly is a disorder of gut brain interaction? It is the perception of normal digestive activity as symptoms.
You're listening to a Nerva podcast, clinical conversations about the science of gut-brain disorders and the real people we care for every day. These podcasts are created from our free webinars, which you can sign up for at the link in our bio.
So tonight, like I said, we have Dr. Omar joining us. He's a gastroenterologist from Illinois Gastro Health. He's a clinician, an entrepreneur, and advisor. He specialized in digestive cancer screening, IBS, the role of AI in GI. He did his GI fellowship at Georgetown University, and he's very active on social media at Dr. OKMD on Instagram and TikTok. I highly recommend giving him a follow. He has great content, very just authentic and entertaining, and just really gives you a good glimpse of what a gastroenterologist does day to day. So Dr. Omar, if you want to give any more of an introduction of yourself, if not, we can hop into the presentation.
Sure. Thank you, Emily. Thank you for the Nerva team for having me here. Just backstory chat, basically. I was at a GI conference, and we've been talking probably for a few months, but when I met the Nerva team at DDW, that's what sort of clinched it for me that, this is something really important, really relevant, worth supporting. So thank you for the invitation. In terms of me, the only thing I'll add is that there are very few gastroenterologists who plan their fellowship around IBS. Very few people think they're going to be an IBS specialist. And one of my mentors told me, he said, "Don't worry, your clinic will be 70% IBS." And we all looked at him with a third eyeball. But that's the case. That's true. And that's just the reality of it. And so it's important for us to be aware of what's new in terms of science. And then also, what are some things that we can offer patients who are suffering from IBS? I probably have a mild case of IBS. My mom definitely has IBS. Good thing she's not listening. She'd be embarrassed. But she definitely has it. So it's very, very common. And IBS comes and goes, and we're going to talk about some cool things here. So my job is to keep you awake for about 40 minutes. So hang with me, ask questions, feel free to interrupt. This is an interactive dialogue. I don't want to be talking to a MacBook Air for 45 minutes. All right. Okay, next. Okay. So I can't see you, but raise your hand if you've heard these terms. Go your gut. So like a lot of sayings in our lexicon, they come from something, right? And so the reason I mention this is because if you have heard this, if you feel this, that is your gut brain. We now know that your gut has neuronal cells that are very, very adaptable, capable, pliable, that serve a number of functions. It's almost, not almost, I think Teenage Mutant Ninja Turtles was onto something. If you know the villain, it was the guy Krang. He was looking at a human body, and then like the brain was in the gut. That's us. Like, that is us. I can't believe I dropped the Teenage Mutant Ninja Turtle reference, but for those of you who know it, you'll get what I'm talking about. All right. So why this matters, like I said, like disorders of gut-brain interaction are common, not just in the US, but around the world, especially in age 65, different anatomy, post-surgical, more medications, more antibiotics, more reasons for gut microbial disruption in the elderly population. Annual cost of GI conditions, that's 136 with a B. So IBS results in ER visits. IBS results in days off of work. It results in days off of school. So for us to understand this so that we can treat it really behooves us overall. Next slide. Or do I do it? Okay. All right. Oh, I think I did. Okay. So special note on women and elderly populations, like I just mentioned. Some people say, why is IBS more common in women? Well, you have a longer colon, you have a wider pelvis, you have other organs that are competing for space in your abdominal cavity. You have fallopian tubes, you have uteruses, you have, ovaries, there's other things. And so the colon will find a place to go. It's very pliable and it becomes almost pretzel-like, especially if you're small framed. So it makes the passage of air and stool more difficult. In the elderly population, they have more medications, they have more antibiotics, both of which are associated with gut microbial disruption, which can be problematic, like we'll talk about later. Weaker abdominal wall and pelvic floor if women are post childbirth. In the elderly population, abdominal surgery, pelvic surgery, what have you, general, musculoskeletal tone changes. And then the rates of bloating and constipation are much, much higher in a female population because of those anatomical factors that I was talking about. So, what exactly is a disorder of gut brain interaction? So, the simplest way to put it is it is the perception of normal digestive activity as symptoms. So we're going to do an interactive test because those of you in the US, it's evening, it might be dinner time, snack time. Australia is probably lunch or brunch, maybe breakfast, I'm not sure. If you have a beverage next to you, whether it's hot or cold, doesn't matter. I'm not judging. It could be beer, tea, whatever. I want everyone to take a sip of it, and I want you to sort of assess the temperature of the liquid. And then I want you to be conscientious of where in your neck or your throat you stop feeling the temperature. So here we go. Hold on. So I'm going to be hesitant about the term normal, but I'll say the physiologic right answer for this question is somewhere in your sternal notch. And that's because the upper third of your esophagus is innervated by skeletal muscle, which we can control. We can clench our neck, we can tighten our throat. After that, the 2/3 is smooth muscle, which is autonomic, right? That's where the gut brain takes over. I can't control what happens past my esophagus. But whether you're able to perceive temperature and at what level is a very good poor man's clue to whether you have visceral hypersensitivity, which is one of the hallmarks of IBS. There's some people, and I completely believe you, that you say you feel the cold or the hot all the way down. I believe it. But a lot of people, half of you, will feel it stop here. So when you ask Van Wilder, but why? That's the $1,000,000 question, okay? Why are some people more viscerally hypersensitive than others? What are those factors, okay? So there's three things, really. So how do you perceive pain? How do you perceive sensation from your GI tract? It has to go to a plexus around your GI tract, then it goes to your spinal cord, then from your spinal cord, it goes up to your brain pain center. A disruption in any three of those places can lead to visceral hypersensitivity. So when it comes to the GI tract, if you have gut microbial dysfunction, by this point, it's well documented that microbial disruption and the prevalence of certain strains versus deficiencies in some strains can lead to gut dysregulation, whether that's motility or absorption or luminal permeability, what have you. So that's your spot there. That's your target. Then the spinal cord. I don't know, like why some people God put an amplifier on their spinal cord and just turn up the volume, like at the beginning of Back to the Future when he cranks it up. That's all it is. It's just an amplifier in your spinal cord, and it's amplifying the impulses coming from your stomach. Why? I don't know. Then you have the brain. So the brain has a part, if I go back to med school, the amygdala, which is pain. Don't quote me on that, but there's a part of your brain responsible for pain, okay? And so ultimately, some people, for whatever reason, have a highly sensitive, hyper-functioning pain part of your brain. So the impulse could be fine, but it's being received wrong. Think of this as an energy circuit in your house. Actually, I never thought about it, but that's kind of a good way to put it. You know, there's a light switch, then the circuit that goes to the breaker goes outside, So any kind of disruption can cause a problem. So I hope this is making sense. Hopefully I'm not getting too much in the weeds here. I need some feedback, chat. Otherwise, I'm just talking to a MacBook Air. So if something sounds off, please tell me. This is one of my most favorite studies of all time. So they did this in Germany. and they took X amount of people in one group, X amount of people in one group. They took a balloon, put it in the butt, inflated it 30 mLs. People without IBS, what did they feel? They felt pressure, like, oh, I gotta poop. People with IBS, they reported pain. And when they looked at the MRIs side by side of both parties, well, in fact, there was increased cortical activity in people with IBS who reported pain with the exact same variable. So I wonder what the compensation for that study was. But anyway, it was in Germany. Okay. So I think my point is both upper orifice and lower orifice, physiologically, you should feel about 6 inches either way of whether it's hot or cold or stretch or distension. Think about it when you have a bowel movement. Everybody has fecal material going through their colon right now, but you don't feel like you have to go until it rounds the rectosigmoid angle and starts to enter the proximal rectum. That's your signal, right? We got potty trained that, okay, I need to address this. So, but then the same thing goes for the same people who felt the hot or cold all the way down. They swear they can feel the fecal material going through at a much higher level than people without IBS. And so they can feel it. That is pain. That is the stretch. That is a distension. You're lucky if you don't have that, you know? Like for people who have that, it's an issue. It's a problem. So I think what's most important, though, going back to the gut microbiome, is that historically, we kind of attributed IBS to like, if you think, then this happens. Like whether some people overshoot the runway literally, some people can't go for days, some people have pain, some people have all of the above. Those are the different subtypes for IBS based on the Rome criteria. And so everybody reacts differently. But what we're learning now is that your gut microbiome can actually influence your brain and several other activities that are super important for like daily living and growth and stuff. So I think that's probably the biggest breakthrough in the last probably 15 years. You know, historically we thought it was a one-way street, but now we know it's a two-way street. But what's cool is that we can't change our brains, but we can change our gut brains. So that represents a therapeutic target, right? So then we can dig into the why and get more into the weeds of the why, but at least now we have something that we can tackle, however we do that. Okay. The 4 lanes of communication, like it's just expanding on the previous slide that it's a two-way street. And so I think what's pertinent to know is that the gut brain can potentially influence, like I was saying, a number of things: endocrine, metabolic, immune, neural. I mean, it's very, very, very crucial as we're learning to a lot of body impulses, primarily because what they're telling us, again, I'm not a microbiologist, but the cells on the level of the gut microbiome are very adaptable, very gelatinous, and very pliable, which means then they become very adaptative to depending on what you are doing to it. Okay, so how do you talk to patients? Well, I think the first thing, and I hope you guys already got this, is like, just because I can't explain it doesn't mean you don't have it. You know, whether that's the disease or the symptom. I think, you know, if you've been around medicine long enough, you'll just see like you learn new things every 3 to 5 years. And, you know, you might have an explanation or a test, you know, 3 years from now that could explain someone who has IBS might actually have a disaccharidase deficiency that's more commercially available to be tested. So the first thing is, you know, your symptoms are real, they're treatable, they're talking to each other, this is modifiable. Please don't tell them it's in your head, there's nothing wrong with you, or just try to relax. I mean, how would you feel, right, if someone told you that? You know, it's just probably doesn't endear good patient-doctor relationship. So like I was saying, bidirectional means modifiable. If signals can be sent both ways, we can intervene from either end. That's what the rest of this talk is about, the levers we can pull. So for clarity, we'll be doing the gut brain, not the brain part. Just to recap, before we tackle what the microbiome does, how it can be affected, and what body sort of, processes it can impact, what is a microbiome? The gastroenterologist 15 years ago doesn't know what that means. It's the collective genome of the microorganisms in a particular environment. Microbes in our gut microbiome keep us healthy. Where do they come from? Breast milk, during birth, human contact. But then after that, all bets are off. And this is where you really see some really like provocative environmental discrepancies. I'll give you an example. If you look at a global map of the incidence of IBD, it's primarily a disease or a disorder of a condition of North America and Northern Europe. Very sanitary conditions, very clean historically cultures. Where you don't see IBD, South America, parts of Asia, Africa, it really builds a lot of credence into the theory that the more exposure that your gut microbiome has on an ongoing basis to external forces, it can become that much more robust and strong from an immunology point of view. Thank you, Prudence. So that is a really provocative thing. And you'll see other discrepancies. You'll see some kind of conditions that are only in the Middle East, like heavy chain disease. There's a certain condition of small bowel malabsorption, diverticulosis. There's still places where they poop in like in a latrine. It's a hole in the ground and they squat. And that's why the squatty potty, don't get me started. But that's basically, people there generally don't have diverticulosis and hemorrhoids. In the West and in Europe, we sit and we push. It's not the right way to do it. In fact, we try to correct it with the squatty potty so that we were sort of squatting, which is what nature intended. So the gut microbiome, coming back to the slide, you start off a certain way, but then environment, diet plays a huge role in, what your current adulthood microbiome would eventually end up being. So on that note, this is a cool study. 2 groups, one from Atlanta, one from Cape Town. They switched diets. In 2 weeks, they had different expressions of inflammation and cancer biomarkers. That's wild. Like, that your diet in 2 weeks could literally change these genetic expressions and these markers on a molecular biopsy level. Yeah. That's, we talk, I think the key culprit here, to go off on a tangent, side quest, is UPF, ultra processed food. I can hear half of you nodding your heads right now. Like, UPFs, there's a cost to convenience, right? There's a cost to having it available. And we're just learning. I think part of that is early cancers, particularly colorectal cancer, other cancers. Every cancer is happening earlier and earlier because Gen X is the Capri Sun, nature first, granola bar generation. I shouldn't pick on those industries, but you get my point. The generation before that generally didn't have that. And so that's what one theory is currently. So, but this study would lean towards a UPF theory that if you eat a whole diet, whole foods around the edges of the grocery store, you can actually impact your gut microbiome. Question: with post-infectious IBS, do you recommend diet first or gut-brain therapy? I would say both. And so just to go down with diets, I'm very, very, very simple about diets. Number one, get more fiber. I won't even talk to you about diet until you're pooping an 8-inch log every day. Until that happens, diet is like a pea pot. It's not going to move. You've got to flush the pipes. That is probably more important than what you're putting into your mouth. So making sure what you have in your body, you're getting out. If you're having rabbit poops or goat poops and you're just not pooping well, you poop every 3 days. No. You need an 8-inch log every day so that you are flushing your system. So, with that said, number one is fiber. And the second one with diet, I just tell people, hey, give me 72 hours. Give me 72 hours. Don't put anything in your mouth that came out of a wrapper or a box or a can. That's my 72-hour challenge. What do I eat? I'm like, there's still a bunch of stuff in the grocery store on the outside, right? Like everyone goes to the middle, like that's where the good stuff is. But there's still plenty of food that you could eat. I mean, he really panicked. Like I was like, it's okay, like, he'll be fine for 72 hours. So yeah, sorry if you guys are eating good food right now. I don't mean to shame you. I'm gonna move on. Okay. So other influences on your gut microbiome, exercise obviously is important and improves motility. Smoking can cause disruption in gut microbiome activity. Post-infectious IBS, there's just a question about that. That can happen after surgery or infections. Think, Shigella, Campylobacter, even H. pylori sometimes. You can have C. diff. It may not be recurrent C. diff. It might be post-infectious IBS when you get a negative C. diff study. Alcohol. We know alcohol can disrupt mucosal barrier and microbiome composition. Early life exposures, depending on the antibiotics you got, how you were delivered, etc. Mood disorders. Mood disorders can also influence. I mean, we know that the brain impulses can affect the secretion of certain neurotransmitters from your gut brain. But the cool thing is that they work both ways too. So we'll get to that. Kevin, is metamucil not a single prebiotic fiber most tolerable high yield options? Good question. I mean, so with the IBS part of it, you have to tease out. You're not going to give psyllium to someone with IBS-D, right? So you got to make sure, it's IBS constipation subtype before you prescribe psyllium. And so I think you can draw a clear line between increased psyllium ingestion and good bowel activity with a more robust and a more diverse gut microbiome. And so I think another key thing is that you don't need the biggest gut microbiome, okay? It's not a contest. What they actually see is that the most diverse and the most replicating and sort of self-generating gut microbiome is the most healthy one. And that's why I harp so much on flushing the pipes. That is such a key part of, and psyllium is actually associated with, absorption of content, absorption of bad fat. It actually helps with your cholesterol levels too, and your lipid management. Would it work for IBS-D? It could. It's not my first line. So that actually, so coming back, because I see this a lot, is it IBS-D, especially in the elderly population, or is it truly fecal incontinence? And the way to find out is by put a finger in the butt. So kind of a different tangent, but I think it depends on the severity of symptoms. I would want to make sure they do what the sphincter tone sort of status is, and it could potentially help. Microbiome, future directions, like we talked about, gut and medication influence composition. There's actually studies that show that your gut microbiome can actually dictate how you respond to chemotherapy. That's pretty provocative. And then it may affect our sleep, appetite, mood, and athletic performance. I'm going to talk about those one by one. So then a future direction. This is just, one of those gray zones, natural versus supplemental probiotics. Should we take them preventively? Is organic food better for the gut microbiota? Technically, it makes sense. I tend to think that locally sourced food is probably the best food. It transported the least amount of time and duration to get to your fridge. In terms of honey, like local bees make honey that can help with allergies. And so folks, they often ask, like, do I do organic? And I said, if you had to choose, I would say locally sourced as much as possible. Dairy, meat, seafood, that type of thing, whenever possible, of course. So those are still questions we have, about probiotics, prebiotics. The data's mixed. I'm going to move on. So let's start with appetite. So we now know that the gut microbiome can actually impact your appetite. There's certain strains of a species of bacteria that are shown to be very important in appetite regulation. And so anytime you have disruption of your gut microbiome, you might be eating more or you might be eating less. Usually people eat more. It interferes with metabolism as well. And so, like I said, there's a number of hormones at play here. Some of these are obviously also in play with GLP-1 agents. But we do know that there's definitely an interplay between the gut, brain, and appetite, including appetite suppression. Let's talk about sleep. So sleep, we thought, obviously one-way street again, right? We were talking about one-way street, but now we know it's a two-way street, that if you have an impaired gut microbiome and you're absorbing things that you shouldn't be, and you're not absorbing what you should be because of intestinal permeability issues, that can cause neuroinflammation. That can cause microglial activation. So that's there. So, and this is a very easy way to actually prove this one. I'll just ask the people, who eat lunch. I'll ask you right now, like the people who eat a salad, it might taste good, it might not taste good. You don't have a post-lunch crash. The people who go out from McDonald's, or fast food, I shouldn't like pejor, fast food or processed food or Italian food or Mexican, whatever the case, you're not very productive from 1 p.m. to 3 p.m., right? So that's a very simple way. If your gut microbiome is absorbing, things in those foods, there is a direct impact. There is a food coma, right? Same thing at home. Like in the evening, if you come home, the person who eats, a chicken breast and broccoli will probably be more cognitively active than the person drowning in the mac and cheese and pasta. It's very simple physiology and biochemistry at play there. So, mood. So, historically, this is probably the most strongest one-way street that we've talked about, where depression, anxiety lead to GI issues, which of course is very common and very much the case. But now, disruption in your gut microbiome and the neurotransmitters that it should be in certain levels, any disruption in those may actually be responsible for mood and mood disorders. And so there's actually a lot of data looking at the incidence of Parkinson's and Alzheimer's and how they're connected to their gut microbiome signatures of people. So going back to the elderly, when they look at their gut microbiome and how they assess it, there are clear associations. I won't go so far as to say causative, but there are clear associations in less incidence of certain neurological conditions with people who have higher levels of certain strains of bacteria. So that data is there. So again, represents a possible therapeutic target. Fix the brain, fix the upper brain too. I think I had one more on athletic performance. I might have skipped, but anyway, there's also some data that a healthy gut microbiome is associated with enhanced athletic performance, and this is you can see this with sleep, athletic performance, where NBA teams, NBA players and the NFL players in the 80s, they would literally have a beer and a cigarette at halftime. Truly, these are professional athletes, but they would do that at halftime. It's almost not even thinkable now, right? The top athletes now, they have regimented diets. They probably have their gut microbiomes mapped out. I wouldn't be surprised if Tom Brady did, So, and then based on that, that's how they fuel their bodies. Eventually, that should get to the consumer, but that top level athletes always, adapt their diet to what they need. And same thing with sleep. NBA teams, they have pods now where they put their players into pods. They take away their devices, they lock the pod, and they sleep. Sleep is so prioritized now. We all, if there's any NBA fans here, in the 90s, Michael Jordan, Charles Barkley, between playoff games, they would go down and gamble and that kind of thing. But that's just unthinkable now because there's just too much money on the line. There's too much at stake. And so taking care of your gut microbiome and other physiological factors, are mandatory at that level. So athletic performance, just want to make sure we touched on that. So, okay, 6:31. Everyone take like a bio break or a stretch break or have a drink. A cig at halftime. Yeah, not here. Not here. We're just drinking water. But they did. They did. I mean, even the Bulls in the mid 80s, I think, did that. In NFL, hockey, very, very common. So yeah, times have changed. So let's spend about 10 minutes or so talking about how we can address this. I've kind of touched on it tangentially as we've spoken, but let's kind of do a little bit of a deeper dive at least what are our menu of options, right? What can we offer patients who are struggling with this? First thing is diet. Try the low FODMAP diet for 6 weeks. Reasonable. I just personally am not a huge fan of elimination diets. I think they are something that you're setting someone up to fail in a way. But if it's someone who's motivated, whether they have IBD or IBS, and they want to do a diet approach, more power. That's fantastic. Generally speaking, these people will self-select themselves. They'll say, hey, I want to do this, do that, and then you can give them some research or data. Sleep hygiene is absolutely critical. So sleep hygiene is, that helps with bowel function, gut motility, all kinds of things. And so sleep hygiene is key. It says skip generic sleep hygiene lectures. It just means, consistent bedtime, consistent time to wake up, trying to eat 3 hours before you go to bed, trying to drink 2 hours before you go to bed, avoid screens 1 hour before you go to bed, just sort of those things. Stress, mind, body. Obviously, stress is a huge problem. Number one. I think that everyone is predisposed to IBS based on how their gut microbiome and the influence and factors that got them to that point. Stress is usually the first domino to tip. And so stress is a huge part of it. And gut-directed hypnotherapy, which is what Nerva provides, cognitive behavioral therapy is important. Meditation is important. One of the really cool things now is virtual reality. You can put on the virtual reality goggles, you go into a clinic, and imagine there's a therapist or a doctor who will literally talk to you for as long as you want to. You decide when the visit is over, and you can talk anatomy, physiology. You can ask about treatment. You can choose if you're sitting on the beach, you're up in the mountains. You can select your environment. I've tested this. Yeah, I felt better after 3 minutes. I was like, okay, I felt better. And then, of course, medication review. I mean, especially in the elderly population, if they're on more than 4 or more meds, you got to cross-check to see which of those has diarrhea, is it possible, constipation, is it possible, cramping, ischemia, all of those things. And, of course, antibiotics. Antibiotics are huge. A 5-day course of an antibiotic kills 30% of your gut microbiome. And then we think it takes about 6 weeks to replenish. Can refer to work with a specialist. Absolutely. Love it. Love it. Use our GI dietitians. They are priceless. They know what they're talking about. They will take the load off your back, and the patient can ask them all the questions. So if there's clinicians attending the webinar, please consider using them. The patient's going to have a lot more questions that you're going to be able to get to. And so ultimately, the best thing there is a dietary referral. It's what they do every day. They know it really well. Thoughts on SIBO testing and treatment? SIBO testing, if available, is reasonable. I mean, the testing is good, not great. Breath testing. I think as the stool testing for gut microbiome signature becomes more commercially available, that's going to be a game changer. meaning that if you want to know what your gut microbiome signature is, you do a stool sample, you get the report. It gives you at least an objective baseline. And then in certain cases, it will tell you, hey, no, I have bacterial overgrowth. And so the other one not to sleep on is SIFO. SIFO is a thing too that people really don't consider, which is small intestinal fungal overgrowth. So that's another thing sometimes, like if you have a case of SIBO and you give them Flagyl or Xifaxan or an antibiotic, what have you, and they partially treat or they don't respond, SIFO could be a thing too. So it's just you mentioned SIBO, I thought it'd be important to mention SIFO too. Okay, so let's take a look. Gut-directed hypnotherapy. Gut-brain therapies are evidence-based treatments that target the bidirectional component pathway. They are highly effective for DGBIs. Societies have actually endorsed these. The AGA and the ACG recommend gut-brain therapies show significant improvement. So the patients that I've put on this, it really is life-changing. Like, I was shocked when I saw the same person back 2 weeks later. I brought a patient back in 2 weeks because she was so, what's the word? Despondent, or just really on the edge, like, with her symptoms. I said, let's try this 2 weeks. I almost didn't recognize her when she walked in. I'm like, that's the same person? And she's like, yeah, I finally know what's going on. I finally know what to do about it. And I was like, okay. She made it sound so simple. So my understanding is that the stool samples for gut microbiome are not evidence-based, as we don't have a definitive idea. Very true. Very true. We do know, again, this is all just accumulating. We do know that certain bacteria in certain levels are associated with XYZ. What the clinical implications of that are is TBD. But we do have data looking at specific bacterial strains. But to your point, what is truly a healthy microbiome? Is it the size? How do you measure that? Is it, how often it turns over? Is it the diversity of it? Should you be eating 30 plants a week? Like the recommendation some people have is, I think that all kind of comes into play. GI mapping, I actually don't have a whole lot of experience about. And GI is one of those fields, actually, folks, like AI, innovation. I've never seen so much innovation in GI as I have like the last 6 to 12 months. So I think it's exciting. So typically in practice, we run with this. Good question. So now you're diving into sort of the Rome criteria. I mean, daily is my personal preference. I just think, that would be a good cadence. Now, 8 inches may be a bit glorious, but I just think it's important. If you're going 3 times a week, travel is different. But if you're in your home routine, I would. My therapeutic target would be a daily bowel movement. Whether we put guidelines around that and define it, I think it's a little bit hard to say. Remember, guidelines are people who come together, they look at the data, and a lot of times guidelines come out. It wasn't 12 to 0, it was 7 to 5, or it was 9 to 3 or something, And so it's all to some degree, subjective. But just, I think, if you're eating and drinking reasonably with good activity, once a day is a reasonable sort of metric to meet. All right, let's see here. Special focus, like we talked about earlier, the 65 plus patient, they have so many extra factors at play that, say, a regular 35-year-old may not. And so, their microbiome changes with age, they have polypharmacy, more antibiotics, and then there's sleep changes, stressors, diabetes, just there's more rings on the tree bark. And so they're more susceptible, and frankly, they're underdiagnosed. I mentioned fecal incontinence earlier. I think that's a really, really big one to not miss in females 60 and up, and even males. But more so, IBS can be very, very underdiagnosed. We tend to think of it as a condition of the 20s to 50s. And I think that's changing because, 60 is the new 30. So Nerva is available at no cost. Hey, Emily. Wow. I didn't actually. Okay.
I've been here listening in.
Oh,
I forget,
there you are.
I can read the next two slides if it's helpful. It's a little more Nerva focused.
Yeah. Please do. That'd be great. I actually didn't even know that till now. That's great for those patients. Then I'll let you talk about it. And then, folks, we have time to talk more questions too.
Yes. Yep. So, Dr. Khokhar has been talking a bit about 65 plus and a little bit more emphasis on the older population. And part of the reason why we asked him to talk a little bit more about that is because we're very excited to talk about a new initiative that Nerva has, where Nerva will be available at no cost for patients who are located in the United States who are age 65 and plus starting Thursday. So right now it's Tuesday in US, in New York where I am. So if you're in Australia, but this is US specific. So starting Thursday, any patients who are referred by their provider will receive Nerva at no cost. One of the reasons why we've decided to do that is, like Dr. Omar said, these patients are often underserved, they're overlooked, symptoms are often dismissed, and options are very limited for this population. Another really interesting thing is that this population, this age range, is often underrepresented in DGBI research or IBS research. If you take a look at an IBS study or DGBI study, you'll see that most of the clinical trials, most of the research skew younger. They often have like a cap on how old patients are allowed to be in order to participate in studies. So we're hoping that by providing these tools, we're hopefully building that evidence base and showing that there's a huge need for that range and age of patients, and we're hoping to support them by taking away some of those barriers. Nerva does have, internal data that we're able to see depending on the users, how old they are, how likely they are to sign up. So we have seen that 10% people 65 and up are 10% more likely to sign up versus other audiences. So we see an increase in patient compliance and readiness to start. They're also 43% more likely to complete. So once again, that patient compliance, we see that our 65 plus population is really on top of it, and they want to do it. They hope, probably are sick and tired of being underrepresented. So hopefully many of them find this a useful tool. So this illustrates that there are no obvious barriers in terms of the adoption of the self-guided digital therapy for this population. I also just want to touch briefly on Nerva referrals, because I think we have some patients in here, but I think it's primarily clinicians who are listening in. So just so everyone's aware, the best way to refer patients is on our online referral form, which you just go to the Nerva website. There's a big button that says refer, and you just put in the patient's information. There is a place where you can put date of birth. So that's how we know how old the patient is. When we see a patient who is 65 and plus referred, they'll be, unlocked free access to Nerva. All patients do have a 7-day free trial that they can cancel at any time so that they can try it out and see if it's a good fit for them. And when you refer patients, you do give them 25% off. So obviously 65 and plus, they're getting it for free. But for those who are younger than 65, you're still giving them about $50 off the program when you refer them. So it's about $150 for an entire year access to the program. So it's absolutely worth referring your patients. They do have a money-back guarantee as well, so there's lots of great benefits to referring. And then also they have access to the patient assistance program. So if you do have a patient younger than 65 who really wants to do Nerva, maybe it doesn't fit quite right in their finances, they can apply for the patient assistance program and get up to 100% of the program covered. So really great to know. Highly recommend if you do have a patient you're seeing that wants to try Nerva or that you think it's a good fit, place a referral for them. These referrals never expire. So if they want to have a think, make sure it's a good fit for them. It's always there for them when they're ready. If you are a patient listening in and you want to try Nerva, tell your clinician about the right way to refer you so that you can get those discounts and benefits as well. I see a couple questions about if this offer will be extended to Australia. I'm not 100% sure because I am on the US team, but I'll ask the team kind of what they're thinking there. And then maybe we're going to be sending out some more information about this program. So hopefully we'll have more clarity on what it's looking like in Australia. In order to refer your 65 plus, someone else asked that question, just place a referral on our website. Just make sure to put the date of birth in there so that we can see how old they are. Yeah, and I think that's all the questions here. Let's see. So Dr. Omar, I'll give you the stage one more time for some key takeaways, and then we have the Q&A session for everyone.
Yeah, I think you know, well, we talked about a lot actually. So I think the key takeaways that I would have is that, now that we know that the gut brain are two ways and bidirectional, we have the opportunity for another therapeutic target for people who are suffering from IBS. The second part would be is that we have a lot on that note, we have a lot of control over how that happens. We can change our diet, we can change our sleep, we can focus on some mood de-stressors, medication reviews. All of those things can play a role in the gut microbiome, healthiness, if you will. And then gut-directed hypnotherapy, it's almost like, why wouldn't you do it, right? I mean, like, it helps patient understand what's going on, which I think is huge. They don't understand half the time. Like, I can't get into that stomach, spinal cord, brain picture with them every time. At the beginning I do, but for them to be able to understand the why goes a really long way. And then they come up with strategies, right? Like, if this, then this. And so I think it's a great option for people. And it'll ultimately, hopefully, decrease the burden that DGBI has on our whole system. So, yeah, we've got time. So, yeah, let's questions, comments, concerns, grievances.
Yes, if you have any questions, please drop them in the Q&A box, preferably. I know there's a lot of questions in the chat box too. I think Dr. Omar went through most of those. We have a couple questions coming in. So Dr. Omar, Ariana is asking, as she said, I've heard that the microbiome can change every 24 to 48 hours depending on what we eat and stress. Does that fit into your understanding of the evidence?
Yes, highly adaptive, highly responsive. And that's why, somebody mentioned about pooping frequency, like pooping every day, flushing the pipes, those things matter. Diet matters. I mean, people who, I'll give some people a 24-hour or 48-hour challenge. I'll say, pick a fruit that you like, grapes and cantaloupe. I'll be like, just have grapes and cantaloupe and water for 24 hours. See what happens. Well, that was fine. Well, okay. But I like Steak and Shake. I'm like, that's cool. Just there's a price of admission then. Okay. That's not on me or you. It's just, if this, then this. That's your choice. It's a free country. So, but it can really clarify what they've been, sort of ingesting. If they can just go 24 hours with, I said fruit, but you can even do something elemental, something whole, non-UPF. That's the key.
Great. And we have another question. I'm assuming this is related to earlier you were talking about, ultra processed foods or energy levels, depending on what people eat for lunch. You mentioned, maybe someone having a salad or broccoli and chicken breast versus someone who's having like pasta or something. So Kimberly asks, are you suggesting no carb is better for focus? What about complex carbs and their benefits on satiety and slowing blood sugar spikes?
Yeah, I think complex carbohydrates, think more brown, that are less refined, definitely play a role, especially, some people who fast or, energy, that kind of thing. I'm a proponent of a balanced palate, right? Even fat is necessary. It's just everything in moderation.
Yeah. And like you mentioned earlier, always refer to those dietitians too. They do this all day long, and if people have a lot of questions, they usually, yep.
Huge resource.
Amazing. This question, go ahead.
No, go ahead. Sorry.
This next question has more to do, we're talking about the 65 plus population. If you had maybe top 3 tips on how to support GI health as you age, what would you recommend?
D-pharmacy, number 1, number 2, number 3. I mean, it really is. I mean, like, just people pick up meds. It's crazy. It's like they go in for pneumonia and they come out with like omeprazole, which, I mean, in the hospital is fine, but they're ended up being on it for like 8 months. And you're like, you're still on this? Like, yeah, I started it when I had pneumonia last year. Like, geez. So the first thing is, And if there's a lot, you can also get a pharmacist to help you. Ask your ancillary staff, your people, your nutritionists, your dietitians, your pharmacists, like they want to help and they do it every day. It's like what they do. So the first thing is just de-pharmacize. I mean, therapeutic de-challenge of medications whenever you can. Cross-check their supplements. So if they're informed, they might be on a number of supplements. I think it's important to at least cross-check and verify which supplements they're taking. Diet, generally speaking, they're not, that's not their Achilles heel. It's mainly the amount of medications they're on, and then if they're on antibiotics, that can also have an adverse effect on their gut microbiome. And especially as women typically in the 60s, their bodies change, and so constipation can exacerbate. When you talk to them, they'll tell you they've always been constipated, but they didn't really get to it until the kids are older and these things and that. And so it's important to address constipation in elderly population.
You also mentioned like fecal incontinence. How do you know when is the right time to bring pelvic floor health into the patient care?
If it was up to me, day one. Anybody with change in bowel habits, constipation, or diarrhea needs to have a rectal exam to assess the pelvic floor and the sphincter muscles and everything to make sure they're working correctly. And if they're not, then early referral for pelvic floor physical therapy.
Great. I think you can see Kevin's question down here asking about intermittent fasting or long fast / bowel rest for IBS. Does it restore balance, microbiome? What are your thoughts on that?
A good question. There's actually some data on intermittent fasting a couple of weeks ago showing some potential adverse effects from that. So there's never going to be a head-to-head trial on that. So it's going to come down basically to opinion. I think it depends on the type of IBS. Is it constipation subtype, diarrhea subtype, or mixed? I think that would have an impact on what you choose. You can't go wrong if clinically appropriate, not diabetic or any other pediatric or something. Even with like a liquid fast, right? That's your bowel rest, just giving it a break. And then going back to somebody else mentioned 24 to 48 hours. Does it restore balance microbiome? So what I'll say is the theory is yes. I don't know the as much research behind it or the time frame behind it. What were the adverse effects? Key summary of the study. I will have to get back to you on that one. I'll have to,
Yeah,
we can follow up on that one, Emily.
Yep, definitely an emerging area of research or more trends, I feel like, around intermittent fasting and bowel rest for sure.
Absolute cutting edge right now of GI, along with cancer detection. I would say gut microbiome and what impacts it and what you can target is the edge of GI research.
Yep. Another question, it sounds like there are certain things that you would recommend moving earlier on in patient care. You mentioned pelvic floor health. Looking at gut-directed hypnotherapy or gut brain therapy specifically, what do you think is going to help move the needle for that to be earlier on in patient care? Because it tends to be something that often comes up as a last resort, or we've tried all these things and nothing worked. How do we move that? How do we change the culture around that?
That is a really, really good question. A lot of it is just hardwired, abdominal pain, scope, right? It's almost a generational shift. I would almost say. I think it's just awareness, right? Like I didn't really know much about this until a few months ago, when you were pretty persistent about it and just sharing that, hey, just give it a try. And I don't have a good answer. It's just more than maybe just generational. We feel historically there's been, try this medicine, try that medicine, do this test, do that test.
Mm-hmm.
So I think maybe they're jaded from, when medical legal stuff came up, in that generation or something. I think this generation is much more patient shared decision making. It's much
Mm.
more here's a menu of options and you tell me, what you're most comfortable with.
Yeah, and I agree with you. I think, we're just learning so much more about what IBS is, what are disorders of the gut-brain interaction, and making sure that we can communicate that to patients as clearly as possible so that they see that the gut and the brain are the key components of what they're feeling, and this, therapeutic approaches that we have that directly address that. We have time maybe for a couple more questions if anyone else wants to filter in. I'm just going to change the slide so that you guys have this QR code if you want to scan it. But like I said, we will send out a recording. We're going to send out the slides, and then you're more than welcome to reach out with any questions. But we have another question. Do you have any preferred gut microbiome tests these days? I've gotten a lot of really useful, clinically helpful data using 16S. I'm not super familiar with that. I don't know if it's something that you use in practice or have heard about.
I've not recommended any. I'm still looking for, and this might be tying back to the previous topic where maybe I'm just still a little more fixed in my thinking, and this is something I should probably be more adaptable about. Because I've had patients who have gotten it done and they bring me the report and it's like 10 pages long. And then I need to figure out well, what are the implications of this, right? Like if this bacteria was present or this one wasn't present, that is fine. I don't disagree with the microbial lab interpretation, but what is the possible causative or associative clinical implication of that number?
And it seems like, it does take a lot to change approaches and behaviors, or even, there's probably so much that you do now as a gastroenterologist that maybe you'd never even heard about or learned about in med school because things change so quickly, and, constantly adapting new behaviors or seeing what the evidence is out there that convinces you that that's the right approach for your patients as well. I think that's all the questions that we have, and we're just about at time. So Dr. Khokhar, I just want to thank you so much again. This is incredible. You did a great job. I think you were very entertaining. A lot of people love the analogies and TV references, movie references. It's great. I think it makes it so much more entertaining. We really appreciate that.
Thanks for listening to this Nerva podcast, where we explore the science behind gut-brain disorders and share real clinical insights from the people we support every day. If you found this helpful, you can join our free webinars for more evidence-based discussions and practical guidance. You'll find the registration link in our bio. We'll see you in the next episode.